Hello, everyone. Thank you for joining us today. My name is Carl, and I'm on the marketing team here at Drummond. I'm excited to welcome you to our webinar on getting ready for HIPAA's biggest rule change. So today's speaker is Michael Henry, our Vice President of Growth and Strategy here at Drummond. And before we dive into the webinar, I just have a couple housekeeping notes. So we'll have a Q&A session at the end. So please feel free to submit your questions throughout the presentation in the chat box that's right on the right-hand side of your screen. And the session is being recorded, and we'll share the recording with any of the materials with you afterwards. So with that, I'll hand it over to you, Michael, to get us started.
Thank you, Carl, and thank you all for joining us this morning, this afternoon. So the Department of Health and Human Services has proposed the first major rewrite of the HIPAA Security Rule in over 20 years. It's not just a tweak. This is a structural shift. So in the next 45 minutes, we'll cover, what's changed, what's at stake. We're going to provide a roadmap to get compliant before the enforcement deadline as well. My name is Michael Henry. I'm Vice President with Drummond Group, particularly overseeing our IT security and compliance team, which includes our HIPAA security team that does the HIPAA gap assessments and validations with those subject matter experts. If you're joining us today and unfamiliar with Drummond Group, we're 27 years old and we're founded with a focus on interoperability. We are the largest ONC Health IT certification body globally and one of only a handful of designated electronic prescribing of controlled substances certification bodies for the US DEA. As it relates specifically to HIPAA, we've performed hundreds of HIPAA gap assessments and audits since the original rule was put into place for companies as small as individual physician practices to as large as multi-billion-dollar medical device manufacturers, and really anywhere in between. During the webinar, we will discuss the HIPAA Security Rule Notice of Proposed Rulemaking, or NPRM. Nothing in the proposed rule is final or legally binding yet. The final rule requirements may differ from what the Department of Health and Human Services has published for comment. Drummond Group has no inside knowledge of whether or when HHS may finalize the rule. So just to be very clear, this is still proposed, and Drummond Group is speaking today regarding what has been proposed. We have no insight or inside knowledge as to whether or not this will be finalized and or what details will be finalized. We're going to talk through 4 items today and a focus on 3 really important questions. What could change? What does it mean for your organization? And what do we do now? We will have time for Q&A at the end of the call. You can add questions during the call as well. And some have already been submitted, and we appreciate you doing that in advance as well. So we're going to discuss, why this matters now, and we are going to take a non-partisan focus. Cybersecurity and security of healthcare is nonpartisan, and so we are going to take it with that approach as well. There's a lot of data out there that is extremely compelling for the importance of cybersecurity. I could go on and on ad nauseum about all the reasons why security needs to step up, and I am gonna cite a few data points here. 2024, 1.7 billion people were impacted by healthcare breaches. We are seeing an unprecedented acceleration in breaches and IT incidences across all parts of the healthcare ecosystem. No one is immune. This includes individual practitioners and hospital systems, to EHR developers, pharmacies, drug fulfillment platforms, and even more recently, we've seen some of the headlines with medical device manufacturers. This spans dental clinics, eye care, physical therapy, nursing facilities. It really doesn't make a difference what part of medicine you're practicing in. No one is immune. It's really everywhere. And the point of this is that regulators are not writing these potential updates in a vacuum. They are doing it in a direct response to the escalation in attacks that we're seeing, and in some cases, due to the direct apathy of covered entities not doing enough and doing the bare minimum. According to a Verizon 2026 data breach investigations report, stolen credentials were the cause of 22% of breaches, and vulnerability exploitation were 20%. The proposed rules MFA guidance and scanning requirements map directly to these two causes. So these are not, again, being proposed in a vacuum. These are directly reasons why breaches occur. Healthcare has had the highest average breach cost of any industry for 14 straight years. The average breach cost over $7 million last year. The drivers to this are not only potentially ransom, the increased costs for detection and remediation, penalties that you may see. It's kind of doing more damage after the fact, where you may be penalized by government regulators as a function of the fact that you had not provided certain assurances that you should have that resulted in a breach. And then in addition to that, lost business driving the cost. And I think that's one of the things that a lot of people don't realize is the potential impact and long-term ramifications that this could have on your business when you have one of these things. It's not just potentially your data gets leaked, it is your business could be shut down for a period of time. The one missing control point is absolutely critical. Most breaches don't come from sophisticated attacks. They come from a single safeguard that wasn't implemented because it was considered addressable, or it wasn't enforced even though it was in place. And believe it or not, this happens significantly more than you would believe, or frankly, just due to the failure of at an employee level as a result of phishing or social engineering, which is continuing to get more and more sophisticated. We were recently engaged with a firm for a social engineering exercise for the entire organization, and our own point of contact who engaged us failed the social engineering exercise. It is something that has to take more of a priority because a lot of these breaches are occurring at the employee level. This is really where annual audits, which collect evidence, come in even more valuable. And we're seeing these not as a regulatory requirement, but you're seeing these as a end customer requirement. The increase in things such as SOC 2 and ISO 27001 requirements from your customers are examples of this. And the reason for that is that SOC 2 and ISO 27001 actually look at evidence that your controls are in place, not just written in policy. This is also the value of having an external auditor, whether it's just a risk assessment or examining your actual HIPAA compliance, because they were not just looking at are your policies and procedures in place correct? On paper, is everything looking good? But in practice, are you actually deploying what you are supposed to be doing? So we're going to move away from the why now to the what. The proposed change removes a good amount of flexibility in the current requirements for covered entities and BAs. Today, organizations have latitude on what reasonable looks like. If we take the proposed rule at face value, the new bar is fixed and verifiable. Controls are becoming mandatory, Scanning and penetration testing is also going to be required with very specific cadences involved. So the bar is really moving higher across the board for what is going to be required, which has not been the case in the past. There are 4 sweeping changes that the proposed rule is putting into effect. So all controls will now be mandatory. There's no more risk-based opt-outs at all. You need to have mandatory technical safeguards in place. That includes encryption at rest for all ePHI. It includes multi-factor authentication, network segmentation. These are no longer optional. Annual verification. This is another piece that is a requirement. You have to have written attestations from your BAs annually, not just a single one-year contract. Additionally, you are expected to keep records from an annual perspective that you have done an annual risk analysis, and that you have also gone through and done an annual audit of your own compliance against every safeguard within the security rule. So those are 2 annual requirements that you are expected to do. Now, backing up to the third bullet point here, a focus on vulnerabilities. So annual penetration testing, semi-annual vulnerability scanning. There is a question later that's already been submitted to the Q&A about the differences between those, and we'll highlight that later. I think this is also a point that some companies overlook. Smaller organizations think that they can get by with doing a pen test every other year. They may not do a pen test because they believe everything's in the cloud and they don't need to do that. It may be covered by another entity. And that's just not necessarily the case. So this is now a new requirement that you need to do this, and it is annual. And if you're running any kind of SaaS-based system, best practice is not only just annual, but it's also after any material update that you have to your software as well. So while BAs have always been covered by HIPAA, there is now a higher burden on the covered entity and the BA annually. The substantial point here is that BAs, although were always covered by HIPAA, the burden of proof, the cadence, and the consequences have really all changed. So a signed BA used to be the primary evidence of BA compliance. Now, every BA must produce annual written verification that the required technical safeguards are in place. A single signed contract is no longer enough. And those all should be kept really for the covered entity. Those should all be kept in a place that is accessible for when that audit comes around annually. A signed BA used to be that primary evidence. It's again, now you need that every year. Self-attestation was generally accepted, again, for the BA. The final rule requires the verification to be supported by subject matter expert analysis. That could require a, excuse me, a third party. It could just have somebody that you verify and can back up with the credentials of being a subject matter expert and being the primary person responsible for this area of knowledge. Notification timing was previously governed by the BAA contract terms in the event of a breach. The final rule actually now mandates a 24-hour window for the BA to the covered entity notification. This is separate from the unchanged 60-day individual breach notification timeline. And a fourth component is subcontractor obligations used to flow only through the BAA. The final rule expands this cascade, so subcontractors certify upstream to BAs, and BAs certify then to the covered entity. So it's the whole vertical now. Termination rights for non-compliant BAs have technically existed since 2013, but enforcement was rare. The final rule tightens the covered entity's obligation to act on a BA's non-compliance, which makes termination a much more active risk and likelihood. So let's talk about how we're going to make this real. We've kind of covered what has changed and how to respond. The last section is really going to be about execution overall, and what you as a covered entity or BA need to do going forward or consider for the final rule. So again, with respect to the timing of potential changes as highlighted at the start of the call, we really don't have any insight into when or if HHS will announce these enforcement or proposed changes. The comment period has closed, and there is an expectation based on the comments and timelines that it could be updated or announced this month. Typically, there is a 180-day window of enforcement when a new rule is finalized. However, departments do have the ability to extend this out further at their discretion. So that is a possibility that would be the case. At a high level, we have created a 5-step roadmap to help you prepare for potential changes. So first, it's important to map and catalog all of your IT assets. Take an inventory, document it. The same goes for those BA agreements. Update your BA-related policies and procedures. So that's the first. Second, you need to run a gap assessment against these new potential controls and additions to the HIPAA security rule. Identify where you already are not compliant with a potential change. And then you need to prioritize those by risk. If you've identified a gap, is it a significant risk versus something else? And you need to now address them in the order of highest risk. For example, adding MFA, if you're not currently using it, it is a significant part of the breach of what causes breaches, highly recommended, as well as, are you encrypting your data at rest? You have to update your policies and procedures. You have to update your BA agreements, but it's, again, very important that you don't just update in writing, but you actually operationalize these. It's something that you have to do in practice and put those forward. And lastly, identify and perform any third-party assurance. This includes penetration testing, and this includes, having somebody independently validate your compliance. I will talk more about this. For what it's worth, penetration testing doesn't have to be done by a third party. If you're a large enough entity and you have a skilled certified ethical hacker or somebody that can do that and follow those policies or those steps internally, you can do that. You don't need to subcontract that out. However, it often provides the greatest value to have somebody who isn't familiar with your system doing that work as well. So here is a plan that should actually say 180 days. I don't know why. Sorry, that must have been a typo. And this assumes the current plan is in place for 180 days enforcement. So in the first 30 days, again, you should really be scoping and assessing, taking that inventory like we talked about. What are you already doing today? Are you already pen testing? Are you already asking BAs annually to recertify for compliance? That gap assessment that we talked about, prepare for it. And then do the gap assessment in the next, after those first 60 days. prioritize your remediation based on any gaps that you have and make a plan for that. And then after that, in the 120 and beyond, you have to validate that you've actually been successful at closing any gaps and engaging any of those parties that you might need to really gain that compliance, whether that is engaging a contractor for MFA. How do you update, your IT procedures for now encrypting data at rest, and the pen testing. If you need to have that done, are you already engaged with a contractor? Same thing also with the vulnerability scanning, something that needs to be done twice a year now. Do you have the capability to do that? Are you outsourcing it to an MSP? What is the frequency that is set up for? So some common pitfalls here to avoid. First is, treating any of this as an IT project only. It's really a governance project. And this includes things like multi-factor authentication, which now may change some of your workflows. It adds potentially extra time for your staff to go in and process data and have access to things. It may not seem as a significant time, but if you have a physician that's maybe seeing 20, 30 patients in a day, all of a sudden now that adds time pretty substantially. So there could be quite a big difference there in the actual workflows that your staff is going through. Another one is skipping the VA verification. This is where most enforcement actions land, and the bar is now stepping up higher. These can no longer be a once check the box activity. You really need to step up how you are managing your BAs. And that is going to be an area that you'll see a lot more of an annualized focus on, and setting up again a process for that, not just to refresh here in 2026 potentially, but how are you going to refresh that on an annualized basis in 2027 and beyond? And that's one of those things that has to be operationalized and put into those policies and procedures. The third point, and I say, this is potentially the most important, waiting for OCR guidance. No matter what actually happens and is proposed, you need to operationalize security. It can actually be a commercial activity. Having these things in place can increase your revenue. They can increase your business. You can't look at them as strictly as a cost center. It is table stakes. It can't be an afterthought that goes to the cheapest bidder. I've had multiple conversations with EHR developers in the last 6 months that have flat out told me we had a breach and we are now updating our pen testing because we haven't done it in a couple of years, and even, hey, can you give us a quote? By the way, we're going to look for the cheapest provider. You're not taking your security seriously if you're reacting. It has to be a proactive activity that you can view and justify as a revenue driver, because without it, you're going to get hurt. So 5 things to remember. The most important is that even if the rule is not finalized, you should be considering these changes for selfish reasons. Putting these in place should give you and your stakeholders greater assurance over the security of your data and operations. A breach, again, does not just take your data. It can shut you down. So, again, the addressable is going to be gone. Everything is going to be required. This is, again, part of the proposed. Putting MFA and encryption is going to be mandatory, not optional. BAs are going to be significantly more accountable with annual verification. Independent validation is going to set a new bar with what you need to do regarding pen testing and potentially using a third-party auditor. Internally signing off isn't going to carry as much substance as it has in the past. So Drummond Group can help. How can Drummond Group help? We do an independent gap assessment against the current or proposed rule. To be clear, even if these changes are not finalized, they are best practices to be considered. We do help with remediation. One of the nice things about HIPAA is that we can support you with how you close your gaps. There are no issues with impartiality. And we also support in-house penetration testing, vulnerability scanning, and can help you set up your policies and procedures. But again, help you identify how to operationalize those items. I think, the thing that is most important is, we can help with continuity and provide assurance that you're remaining compliant, not just setting up for compliance. Again, Drummond has been an ONC authorized health IT certification body for over 15 years. We have a variety of compliance programs that we support, particularly on the security side. We've worked with hundreds of healthcare entities and BAs assessed annually. We do all of this in-house with the penetration testing, risk assessments as well. And I believe with this, we are going to shift to some questions.
Perfect. Thank you so much, Michael, for the presentation and going through all of everything for the proposed rule. We have a couple questions. I'll let you kind of go through in the comment section as well. I think we have 5 or 6. And we also have 4 or 5 from folks that submitted them when they registered. So, yeah.
Great. Yeah, and I do remember there was a question about the difference between vulnerability scanning and penetration testing. So I'll start with that one in particular. So with respect to that, vulnerability scanning is automated. It is done by software. And you typically engage a software provider. Your MSP, if you're working with an MSP, typically has one that you could work with. Drummond, we actually do offer this. We work with both Tenable and Qualys, and they are doing a superficial scan of your environment. They may be doing it continuously, or they're doing it, at a moment in time. The new proposed requirement would be to do twice annually. The way that I describe this, vulnerability scans are an inch deep and a mile wide. That compares to penetration testing, which I describe more as an inch wide and a mile deep. So penetration testing is a manual exercise led by a person. That's how we do it at Drummond. Some companies will tell you that they have AI automated pen testing. We don't support that. Penetration testing is done by a security engineer who is following a set of guidelines on how to ethically hack your system, whether that's your internal network or your web-based application. That's kind of how we do it. And there's a variety of different ways that we do that as well. So another question is around the MFA. So as part of this rule, would MFA become mandatory for the covered entity? The requirement is pretty clear that the answer to that is yes for now. Again, it is proposed, so it is possible that they do not. I see this, personally, and again, we have no insight, as a higher likelihood part that if there is an update, that this is something that would pass or would get implemented. And the reason for that is that it is an easier lift to implement in comparison from a cost perspective. And as I had reported earlier, the lack of MFA leads to a very large number of breaches. So I think this is one of those areas that, resets the bar and becomes table stakes. And then there's a question, again, on this MFA topic about, MFA capable versus MFA enforced. That's an interesting nuance. My understanding, is that it would be MFA implemented. So you, as the covered entity, would have to implement MFA. If your client decides not to implement, then they, as a covered entity, would be in violation. So that's my understanding, and certainly, open to discussing, more of those nuances offline if it would be helpful. Question: if the security rule isn't finalized, are there any proposed requirements we should prioritize anyway? Yeah, great question. So, from our perspective, and, we are a security audit firm and a compliance firm, so we have biases around this. Penetration testing is table stakes. It is should be done by every company annually at a minimum. That is a best practice. Certainly, if you are in the software ecosystem, whether you're SaaS-based or not, and then if you're a hospital system, pharmacy, any other type of organization, even a smaller doctor's practice, absolutely penetration testing is something that should be done annually. We worked with an EHR developer earlier this year who the day of the test, by the end of the day, we had elevated our status to admin by the end of the day. It happens more often than we would like to see happen. So we definitely recommend at a minimum annual penetration testing for sure. Question: do I need a third auditor to be HIPAA compliant? I'm assuming that's a third party auditor. Absolutely not. So you certainly do not need to be to utilize a third party auditor. We believe that having a third party help you just provides that additional assurance. Even if you do it as a one-off, one time, a lot of our customers actually do return to us every single year for us to revalidate and see that they're properly executing HIPAA. And again, that comes down to, again, the policies and procedures may not be changing, but are they actually being enforced? Is it operationalized? So short answer, no, you do not need a third-party auditor, but it definitely helps provide a certain level of assurance that you've done that. And I'll just say, if you're already going through other security assessments, for example, SOC or ISO or any kind of other risk assessment, oftentimes those activities can be bundled together. Sorry, I'm just scrolling through these now. The difference between the current HIPAA security risk analysis and the proposed annual compliance audit. Yeah, that's an interesting one. So the HIPAA security risk analysis is basically a risk assessment of your business, right? So looking at from a security perspective, what are the risks within our business? And there are NIST-based frameworks you can utilize to do that risk analysis. They're free, they're out, they're public. So you have that. And then the actual proposed annual compliance audit is looking at all of the clauses or controls covered by the HIPAA security rule and saying, are we actually following this? Now, what's important is if you are ever audited by OCR, you need to have evidence that you've been doing these things annually, saved somewhere. So that's not just if OCR audits you, but if you have a breach and you want to avoid additional penalties, you need to have all of this evidence prepared from prior, from prior years, saying, yes, we've done every year our HIPAA security risk analysis. And every year we've done our annual compliance audit. And here's what we did. And here's the results of those. And it can help mitigate potential fines because you're demonstrating that compliance. If you actually don't have that, you do have an event or an audit, that is where the fines can really step up. There's a question about the comments discussion regarding client use of MFA. What about internal employee access? So from my perspective, that is actually the primary focus of the MFA requirement, is your own internal employees, developers, system admins. They are the main focus of those that require to use MFA. It is actually not so much on the client side as much as it is the internal. The reason why on the client side, there's sometimes clients that you can't enforce them doing that. And that is something that we hear often, that there's a limitation in the enforcement that you could push through to your clients, the training you can require for them about phishing, even if maybe you're using a contractor. So the MFA focus here is actually more so on the internal employee side. There's a question, besides attestations, will any other document or data need to be submitted for the proposed compliance? So there's nowhere that necessarily you have to submit any evidence. This is all, call it a self-declaration process that you have to be prepared in the event that you are audited or have a breach. So nothing is being submitted, but you should have all of your policies and procedures for HIPAA stored and saved somewhere specific. You should be reviewing that annually. You should have proof of those reviews being saved. Any training, the proof of the training should be saved. Everything you should be storing in the event of an audit or breach. And I see those are the questions that were entered. Carl, were there a couple other questions provided in advance, or did we cover those? Okay, here we are.
Yeah, there's 3 questions, so this is one of the first ones.
Yeah, so the annual compliance audits, again, so just covered this. It's not required to be published or submitted anywhere specific. The only time you would be required to, provide it is in the event of an audit. That being said, also, I guess another one is if you are a BA, it is possible that the covered entity could ask you for the evidence that you have this. And we see instances of that increasing across security in general, where companies are asking their vendors for proof of security. For example, we want to see your SOC 2 report. We want to see your pen test report, things like that. We've been asked even internally at Drummond Group, hey, can you please provide us your pen test report? So it is possible that your customers or other stakeholders will start to ask for these things as well. Does it impact MIPS reporting? Not to my knowledge. So this is a completely separate cadence that is also required outside of MIPS. Now, MIPS does have to do with quality. So it is possible that some of these changes may benefit your score in long run as you maybe see improvements in quality. But it is the actual reporting is my understanding there's no impact. How does this impact EPCS facilitation? Again, so this has no impact on your EPCS certification, which would be done every other year. So I see the question about audit cadence. So this actually, you could argue this becomes a little bit more burdensome because HIPAA is even more so now an annualized activity, where EPCS is every other year for that certification. Yeah. And I do see we had another question coming in about MFA. And whether that's mainly logging into databases or AWS services. So that's a really great question. And, I think we may see a little bit more clarity on that with a potential final rule. However, I think what I would assume is that this impacts any system where PHI exists. So if that database or AWS, server, whatever you're doing, if you are passing PHI through that is where the MFA would be required. Carl, do we have any other questions?
No other questions so far, but I'll let the audience kind of have a little last second question if they do have it to put it in the chat. And go from there.
One thing I'll highlight is we do provide a free HIPAA consult with our auditors, with our actual auditors. Happy to facilitate that, here at Drummond. That's not a sales pitch. We're here to help and support.
I don't see any other questions. But again, thank you, Michael, and thank you everyone for taking time out of your day to join us. And like Michael said, on the screen there's a QR code, so you can book a free Drummond consult to address any HIPAA questions you have or whatnot, or from questions from this webinar. And with that, I hope you all have a great day, and we look forward to seeing you at our next webinar.
Right. Thank you.
Actually, I just see 2 questions just came in. So do we want to address those?
Yeah, sure. Do you have any recommendations for where to save your HIPAA documentation? That's a really good one, because in the event of a breach, you would if your systems are if you're unable to access your systems, you may be unable to access that. So there are places where you can do that. Physical copies, believe it or not, in some cases make sense, especially for incident response plans and contingency planning. Happy to follow up maybe a little bit more in detail with that, and actually could even pull in from an auditor, what we've seen in the real world with that. And then I see in the client side, is it optional right now? Optional, right, even though they have the PHE information. So if you are a covered entity, and I'm assuming this is again related to the MFA, your systems with PHI need to have the MFA. That is what is being proposed. So it might make sense to have a follow up to get into your specific instance or specific questions a little bit more. And I do see a third question about the recording, and yes, the short answer to that, Carol, is we will definitely make that available. Excellent.
Perfect.
Right.
Well, thank you again.
Thank you.
And thank you for everyone, and have a great day.